discuss today cranial nerves and their lesions. Uh, this is a picture from probably atlas, renowned atlas, and it is showing these 12 pair of cranial nerves. Cranial nerves are what basically you know that these 12 pairs of cranial nerves are part of the peripheral nervous system. The Roman numerals which are shown with these cranial nerves is basically based on descending order of the cranial nerves attachment to the central nervous system. Here you will see initial two nerves, olfactory nerve, cranial nerve 1 and optic nerve, they are attached directly to the brain, and other 10 pairs of cranial nerve starting from oculomotor nerve downwards, they are attached with brain stem, midbrain, pons, medulla, and they are numerically numbered with Roman numbers with this descending order of their attachment with this ventral part of the uh, brain, mostly with brain stem, means midbrain, pons, and medulla. So, as a rule, cranial nerves do not cross in the brain. Means, as we see in tracts in the spinal cord, they decussate on opposite sides, but in cranial nerves, their nuclei they descend directly downward and supply the cranial structures, but they do not cross to the opposite side, except for a few fibers at optic chiasma in second cranial nerve, optic nerve, where some fibers decussate and cross to opposite side. Cranial nerves may be sensory, they may be motor, they may be both somatic or parasympathetic, or they may have mixed components. So this diagram already shown. Cranial nerves can be pure motor, is third, fourth, sixth, ninth, and 12th cranial nerve. Here we can see third cranial nerve, that is pure motor. Fourth cranial nerve is also pure motor. Third and fourth are involved with extraocular muscles. Similarly, sixth cranial nerve, abducens nerve, this is also involved with extraocular muscles. It is also pure motor nerve. And hypoglycal nerve and accessory nerve. These five are pure motor nerves. What are the pure sensory nerves? First means olfactory nerve, optic nerve, and vestibulocochlear eighth nerve. So olfactory nerve, this optic nerve, and this vestibulocochlear nerve here. These are pure sensory nerves. What are the mixed cranial nerves? Means having motor and sensory components. Fifth means trigeminal nerve, facial nerve. Seventh, ninth, glossopharyngeal nerve, and vagus nerve. They are mixed nerve. So fifth, this trigeminal nerve has sensory and motor components. This facial nerve, seventh, is also sensory and motor components along with parasympathetic components. And in addition to that, we have glossopharyngeal nerve that also has mixed components. Sorry, and 10th cranial nerve, also very large cranial nerve, that is called vagus nerve. Here you will see vagus nerve. It is also mixed components of or mixed fibers of sensory and motor nerves. What are the cranial nerves carrying parasympathetic fibers? Third, oculomotor nerve. Seventh, facial nerve associated with salivary glands and lacrimal glands. Ninth, glossopharyngeal nerve. It is also parasympathetic components. And 10th, vagus nerve having widespread abdominal visceral parasympathetic innervation. So third cranial nerve, oculomotor nerve, has parasympathetic component. Seventh facial nerve, ninth glossopharyngeal nerve, and vagus nerve. These have parasympathetic components or parasympathetic fibers along with normal sensory or motor fibers. This is chart showing simply about all the cranial nerve structures and their uh, structures which they innervate and the function. So as you can see, olfactory and optic nerve, first and second cranial nerves, they are basically pure sensory nerves. Olfactory epithelium is innervated by olfactory nerve and retina is innervated by optic nerve. Function of the olfactory nerve, well known, olfaction, sense of smell, and of second cranial nerve is vision. You can see here brain stem nuclei, because they are direct extension of brain, so they don't have brain stem nuclei. All cranial nerves have brain stem nuclei where they originate and supply the peripheral parts of the cranial structures. After that, oculomotor nerve, which as we discussed before is pure motor but has parasympathetic component as well. And along with trochlear and abducens nerve, which are also pure motor, these three cranial nerves supply the extraocular muscles involved with eyeball movements. So main extraocular muscles are supplied basically by oculomotor nerve, that includes superior rectus, inferior rectus, medial rectus, inferior oblique, levator palpebrae muscles, which are involved with movement of eyeball, and they have oculomotor nucleus in the brain stem in midbrain. Parasympathetic fibers associated with the oculomotor nerve, you must know. They have parasympathetic fibers with innervate pupillary constrictor muscles, ciliary muscles of eyeball, which are intrinsic eye movements, which are associated with intrinsic eye muscles. These are extrinsic eye muscle movements associated with the extraocular muscles, and they have motor supply from oculomotor. While intrinsic pupillary muscles are supplied by parasympathetic fibers in oculomotor nerve, and their function is pupillary constriction and accommodation. Trochlear nerve, it supplies only one extraocular muscle, superior oblique, which again is involved with movement of eyeball. Then abducens nerve, sixth cranial nerve, which supplies lateral rectus, pure motor, movement of eyeball, abducens nucleus in brainstem. This trigeminal nerve, very important nerve and usually placed in your exams, is also mixed nerve. It is sensory and motor components. Majority of the sensory supply of the cranial structures is by trigeminal nerve. It supplies or it innervates the face, scalp, cornea, nasal and oral cavities, cranial structures, dura mater. These are all sensory innervated by trigeminal nerve. And the purpose of these sensory innervation is basically general sensation, and the nucleus lies in trigeminal sensory nucleus in the brainstem mainly. Motor component of trigeminal nerve innervates the muscles of mastication and tensor tympani muscle. Muscles of mastication involved with chewing, swallowing, not swallowing, sorry, but chewing, and basically opening and closing of mouth. Then coming to abducens, we discuss seventh facial nerve, which is again mixed motor nerve, mixed motor and sensory nerve along with parasympathetic components. Sensory is only anterior two-thirds of tongue, visual sensation, taste associated with taste, nucleus solitarius in brainstem. Muscle of facial expression, motor component, and stapedius muscle, which tensions ossicles of the inner ear. So their nuclei lie in motor nucleus of facial nerve in brainstem. Parasympathetic fibers in facial nerve, They supply are innervates salivary and lacrimal glands via submandibular and pterygopontine ganglia, and the function is salivation and lacrimation. And the nucleus is superior salivatory nucleus in brainstem. Eighth, cranial nerve, vestibulocochlear nerve, which is pure sensory nerve, along with this glossopharyngeal, olfactory, and optic nerve. So these four are pure sensory nerve. Vestibulocochlear is again pure sensory associated structures that it innervates is cochlea and vestibulocochlear apparatus. Cochlea we know is associated with hearing function, and vestibular apparatus associated with balance of head, proprioception. Nuclei of cochlea or cochlear nucleus in the brainstem, while vestibular apparatus vestibular nucleus in the brainstem. Glossopharyngeal nerve is again a mixed motor nerve with sensory and motor components. Sensory supply of the glossopharyngeal nerve is eustachian tube, middle ear, carotid body, and sinus. So in eustachian tube in middle ear, there is general sensation, while chemo and baroreception is associated with carotid body and sinus sensory reception, while pharynx in posterior 1/3 of tongue is also supplied by glossopharyngeal sensory nerve for test. Motor nerve of glossopharyngeal is it supplies posterior pharyngeal muscle stylopharyngeus involved with swallowing. Parasympathetic fibers of glossopharyngeal nerve supply salivary glands via the otic ganglion associated with salivation. Vagus nerve, large and very important nerve, which is main function of sensory along with motor and parasympathetic components. Sensory supply of the vagus nerve includes pharynx, larynx, esophagus, and external ear for general sensation, while aortic bodies and arc for chemo and baroreception. We know thoracic and abdominal viscera are also sensory supplied by vagus nerve for visual sensation. Motor component of vagus nerve supplies soft palate, larynx, pharynx, and upper esophagus is involved with speech and swallowing. Parasympathetic fibers in vagus nerve supply cardiovascular, respiratory, and gastrointestinal systems. So these nuclei, these are the nuclei associated with vagus nerve: trigeminal sensory nucleus, nucleus solitarius, nucleus ambiguous, dorsal motor nucleus of vagus, and this anatomy must be relevant with these nerves, and it is not in the topic that we can discuss today, because discussing anatomy would be very lengthy task today. Then accessory cranial nerve, it is pure motor nerve along with hypoglossal nerve, which is also pure motor nerve. Accessory supplies only two muscles, sternomastoid and trapezius muscles, which are involved with movements of head and shoulders. And hypoglossal is a motor nerve, pure motor nerve, which supplies intrinsic and extrinsic muscles of tongue, associated movement of tongue. So this is all we discussed, different cranial nerves and their associated structures that they supply. This is briefly about cranial nerve palsies. Cranial nerve palsies can be upper motor neuron type, can be lower motor neuron type. Upper or in which the cortex is involved, like upper motor neurons are involved, and lower in which the nucleus or peripheral branch of the cranial nerve is involved is lower motor neuron type cranial nerve palsy. Starting with olfactory nerve. So it is pure sensory nerve which supplies sensory fibers to olfactory epithelium in nasal cavity over here. These olfactory nerve fibers converge in olfactory bulb. So by these cribriform plate, these olfactory nerve converge in olfactory bulb, and then it is only cranial nerve that is directly attached to cerebrum. Here you can again see this is cribriform plate. Through cribriform plate, olfactory nerves converge in olfactory bulb and is attached with directly cerebrum on the undersurface of the frontal lobe here. And you can see optic nerve and chiasma posterior to it. You may find hyposmia or anosmia when there is bilateral and transient rhinitis, usually associated viral infections or allergic rhinitis. It is a common phenomena, means having simple hyposmia or transient anosmia. When there's unilateral anosmia, you must suspect that there must be damage of the file of olfactory through cruciform flat of the ethmoid bone. There may be head trauma, skull fractures. Olfactory bulb and tract damage may occur from tumors, meningiomas, and gliomas in case of unilateral hyposmia or anosmia. There is a variety of seizures or fits which are called uncinate fits or olfactory hallucinations, which are usually unpleasant hallucinations. And these are due to the lesions in the olfactory cortex, which is uncus, gyri, hippocampi. And those lesions may be tumor like glioblastoma. So rarely in patients you may find only olfactory hallucinations which may be transient, unpleasant olfactory or sensory smells, and it is type of epilepsy. You say it is symptomatic epilepsy or symptomatic seizures. How you test is testing the ability to smell or to identify different smells. Each nostril is tested separately. The patient tries to identify the odor with eyes closed. Recommended things are perfumes like flowers, spice like peppermint, coffee, tobacco, means common things that should be given to patient to smell. Avoid substances which can irritate the trigeminal nerve like ammonia and nausea. Usually, olfactory nerve is not asked to test in examinations. This is a very important nerve and very commonly tested for examinations. Optic nerve, second cranial nerve, which is again pure sensory nerve, and it supplies special sensory fibers for sight. Optic nerve nuclei are located in the lateral geniculate body. I will show you later. Here you can see optic nerve, and this nucleus lies in the lateral geniculate bodies. From retina it starts, leading to optic nerve. Here the fibers of optic nerve, medial fibers, they decussate to opposite side and they form optic tract. And second fibers start from lateral geniculate body in optic radiations, and they are finally relayed in visual cortex. What optic nerve examination includes? Visual acuity, optic fundus and disc, in which you can see papillary edema and visual fields. I will show you later. First, we will discuss simply about various and important manifestations of optic nerve damage, optic nerve and its posterior structure damage. From basic anatomy, you must know the ocular system reverses the images. The image that is produced is reversed ultimately at occipital cortex. Optic chiasma, as I discussed earlier, here fibers, medial fibers of both optic nerve decussate, means the fibers involved with which field of examination? The lateral or temporal side fibers from both eyes, they decussate here. So damage anterior to the chiasma will lead to scotoma or monocular blindness. Here you can see 1 and 2. This is optic chiasma. Any damage anterior to this will always produce either a scotoma or small deficit or monoocular blindness like this. This is monoocular blindness. This is our monoocular blindness as well, along with the superior scotoma here. So any damage anterior to the optic chiasma will produce what? Monocular blindness or scotoma. While, sorry, lesions at the chiasma will produce what? Heteronomous hemanopia or bitemporal hemianopia. We know there is partial decussation of fibers in optic nerve. So nasal fibers that carry temporal field of vision from each side decussate and they cross to opposite side. So lesions at optic chiasma will cause loss of temporal side of visual field of both eyes, and it will lead to bitemporal hemianopia or bitemporal vision loss or heteronomous hemianopia. And what is hemanopia? Basically, hemanopia is lesion of chiasma, and posterior to chiasma, any lesions will produce hemianopia, while any lesion anterior to chiasma will produce complete or monocular blindness or some scleromas. At optic chiasma, it will produce bitemporal hemianopia or heteronomous hemianopia. And after optic chiasma, you can see at this optic tract site or optic radiation size, all the hemianopic defect will be homonymous hemianopic defect, means same side of the field is involved. Either right homonymopia is in this field or left homonymous hemianopia. As here it is seen a right homonymous hemianopia in all the deficits that are produced after optic chiasma. So any damage posterior to the optic chiasma will give homonymous hemianopia, while any damage anterior to the optic chiasma will produce scotoma or monocular blindness, or damage at the level of the chiasma will produce what? Bitemporal hemianopia. Then optic radiations, if there is damage at optic radiation levels, you can see you may have superior or inferior hemianopic defects. And in the last, at the visual cortex level, if there is damage, if it is damage on the one side, it is homonymous hemianopia, and if bilateral cortical visual cortex is involved, it will cause cortical blindness. This is a very important concept and very cumbersome and difficult sometimes to understand, but I can only try my best with this video recording to get you to this concept of hemianopic defects. What is hemianopic defect? What is homonymous hemianopic? And what is heteronomous hemianopic defect? And what is scotoma? And what is monocular blindness? So depending on the level of injury, you may have scotoma, simple, monocular blindness, you may have heteronomous hemianopic defects, and after that you may have homonymous hemianopic defects and cortical blindness. Impaired ocular movements may be due to disorders of gaze, or they may be due to disorders of cranial nerve, third, fourth, or sixth, oculomotor, trochlear, and abducens nerve. Disorders of gaze basically are supranuclear or central disorders. This is not involved with our topic of presentation of cranial nerves, but to differentiate from other disorders, I have just shown you these slides. So disorders of gaze is basically, gaze disorders are not basically purely cranial nerve disorders. These are supranuclear or central disorders, and they may be horizontal. What is the difference between disorders of gaze produced by supranuclear central and those produced by cranial nerves like third, fourth, and sixth? There is conjugate division of the eyes in case of disorders of gaze associated with supranuclear or central structures like frontal gaze nucleus or pontine gaze nucleus, while in case of disorders of gaze associated with third, fourth, or sixth cranial nerves, disconjugate deviation of the eyes occurs. In these disorders associated with supranuclear or central uh, gaze centers, like for example, frontal gaze center and pontine gaze centers, patients do not complain of diplopia or some divergent squid. You can not find usually on examination, but in case of disorders of gaze associated with third, fourth, or sixth nerve, patient will usually complain of diplopia, and you may find squint also. This was not usually or actually related with this topic. So impaired ocular movement, this is what is included in our topic. Impaired ocular movements are associated with third, fourth, and sixth cranial nerve. Third oculomotor, fourth is trochlear, sixth is abducens nerve. And what they give, they show on examination paralytic strabismus or squint. This is not associated with disorders of gaze, of central or supranuclear structures. And the impaired ocular movements associated with these cranial nerves, third, fourth, sixth, also produce double vision or diplopia. This is basically a diagram showing you for simplicity from midbrain. Here you can, this is pons and medulla, third oculomotor nucleus, trochlear nucleus in the pons, and here in the medulla abducens nucleus. They supply basically what? Most of they supplies extraocular muscles, and oculomotor nerve supplies majority of the extraocular muscles like superior rectus, medial rectus, inferior rectus, and inferior oblique. Lateral rectus is supplied by sixth cranial nerve, and we can see here trochlear nerve supplies superior oblique muscle. This is oculomotor nerve, third cranial nerve, which is somatic motor component that supplies superior, medial, inferior rectus, and inferior oblique muscles. Here you can see third cranial nerve rising from midbrain structures and enters the orbit through superior orbital fissure and supplies these extraocular muscles along with intrinsic eye muscles as well. So it supplies also to sphincter pupillae muscles involved with pupillary constriction. So origin is from midbrain of cranial nerve 3. Innervation, it supplies extraocular muscles except for, as we saw here, superior oblique and lateral rectus. All extraocular muscles are supplied by third cranial nerve. It supplies muscles of eyelid, ciliary muscles, and sphincter of iris. What are the functions of oculomotor nerve? Eye movement almost in all directions except for few which are by third and sixth nerve. So immediately upward, downward, and outward eye movements are by cranial motor structures involved with oculomotor nerve. Pupillary constriction, shape, and equality is also maintained by oculomotor supply. It also elevates upper eyelid. Accommodation reflex is also function of the oculomotor nerve. Its dysfunction can lead to what? Patient has difficulty to look up, down, or on the medial side. So patient may have disconjugate gaze, as we discussed before. You may find ptosis, you may find pupillary dilatation. It may be bilateral or ipsilateral problem, and there is loss of accommodation reflex. So in clinical evaluation or examination, you will see for eye opening in asymmetry on inspection, as here you can see there is ptosis on this side, and here you can see pupillary dilatation, eyes turned laterally and down compared with this normal side. So because of the loss of this medial rectus muscle, eyes is turned laterally. You will check for direct light response and will see if there is brisk, sluggish, or non-reactive light reflex. You must also see for oculomotor nerve indirect response, light response, or consensual response. Either see it is present or absent. Check for pupil size and shape, accommodation, and ultimately these extraocular movements in all directions. This is the picture showing a patient with oculomotor palsy. On left side, you can see here there is ptosis, complete eyes completely closed. And if you elevate this eyelid, you will see there is divergent strabismus, means there is a squint and eye is deviated laterally and downward. And you will find that will be paralysis of the most muscles of the eye movements, and accommodation will be absent, and pupil will be dilated. Reaction to light will be absent. Here's another picture showing here divergent strabismus, or pupil is eyeball is turned outward and downward. There is, you can see pupillary dilatation compared with this pupil, and there will be paralysis of most movements of the eye. Causes of third nerve palsies may be many, include most major causes of CNS disease. So choice of diagnosis test should be based on the clinical features of the palsy. Intraorbital structural lesions producing external ophthalmoplegia and ocular myopathies should be distinguished from cranial nerve disease. Exophthalmos or anophthalmos, a history of severe orbital trauma or an obviously inflamed orbit suggests restrictive orbital disease, which may impair ocular motility. Myopathies, it is usually they are harder to diagnose but are suggested by a partial third nerve palsy. And again, pupil is normal in majority of myopathies. So extraocular muscles may be involved, not necessarily with oculomotor nerve. They may be involved primarily with diseases of extraocular muscles, for example, in various dystrophies and myopathies. But intrinsic eye muscles will usually be spared in cases of myopathies compared to the oculomotor nerve when it is involved. These are also important concepts to conceptualize with associated with third nerve or ocular nerve palsies. When you see completely non-functional parasympathetic fibers or fibers causing damage of these fibers causing fixed dilated pupils, it strongly suggests some surgical cause or oculomotor nerve compression. When the pupil is spared, while the muscles, extraocular muscles are involved, usually important causes are medical causes like diabetes and other vasculopathies associated with cranial nerve, third cranial nerve involvement, oculomotor palsies. While in case of surgical causes, usually pupil is involved and is fixed and dilated. Surgical causes like aneurysm, some intracranial mass lesions. Oculomotor palsies is in increasingly unresponsive patients suggests transtentorial herniation and is a major emergency. This is also a very important concept to conceptualize. When you see a patient in wards or in ICUs which is going in coma stage, and after some time you notice there is third nerve palsy in this patient, in a comatose patient, it usually suggests that intracranial pressure is increasing and patient is going into transtentorial herniation, and it is an emergency situation. Then trochlear nerve. Trochlear is basically Latin word for pulley. As you can see, this arises posterior from brain or pons and comes in the form of pulley anteriorly to supply the extraocular muscle superior oblique in orbital structures. This is how it enters from superior orbital fissure So it supplies superior oblique muscle. Again, its injury can lead to diplopia due to eye drifting upward, especially when looking down. I will discuss trochlear again with abducens muscle. Abducens muscle supplies lateral rectus. Damage to the nerve is seen with decreased ability to abduct the eye. So affected eye is pulled medially. This is comparison of trochlear nerve damage and abducens nerve. Trochlear originates from midbrain, abducens from pons. Trochlear innervates superior oblique muscle. Abducens innervates lateral rectus muscle. Function of the trochlear fourth cranial nerve is down and inward movement of the eye through superior oblique muscle, while function of the abducens nerve is outward and lateral movement of the eye. Dysfunction of trochlear can lead to loss of downward inner movement of the eye or disconjugate gaze, leading to diplopia. Dysfunction of the abducens nerve will lead to loss of lateral eye movements or disconjugate gaze. Again, it can lead to diplopia. Clinical evaluation of these fourth and sixth cranial nerve is done usually along with third oculomotor nerve with testing of extraocular muscles through extraocular movements. So they are basically tested with oculomotor nerve. This is fourth trochlear nerve palsy example. Here you can see if you can identify the damaged side with trochlear palsy. So trochlear nerve palsy is a rare palsy. And what happens in trochlear nerve palsy? There is weakness of downward gaze. Especially there is double vision when patient is looking downwards and inwards. You can see patient can look from this side, left side, downwards and inwards. But this eye is, you can see drifting upwards when patient tries to look downwards. So this is affected eye on the right side. It is slightly drifted upward compared to this normal side, left side. So to compensate this defect, sometimes patients tilts heads downwards on the opposite side. Here you can see, to see the images on the downside, patient tilts the head downward on the opposite side. As you can see, the head may be tilted to the opposite side to minimize diplopia. Diplopia is vertical in case of this trochlear nerve palsy, while diplopia is horizontal in case of sixth nerve palsy like abducens nerve palsy. This is example of abducens nerve palsy. You can see, if you can identify, this eye is, patient is looking towards left side, so this eye is moving normally medially, but this eye should also in conjugate gaze should look laterally, but you can see it is fixed and hardly moves beyond this center towards left. So this eye is involved as there is lateral gaze palsy and patient is unable to abduct the eye in the left side or left field of the vision. So there is failure of abduction on the affected eye on looking to the paralyzed side. There is horizontal diplopia associated with the abducens nerve. We discuss vertical diplopia associated with trochlear nerve. I think this is not so much important to discuss. Sixth cranial nerve is very important when it is involved or when there is isolated sixth nerve, especially. It is common finding after third cranial nerve. So as we saw, eye is turned inward, it moves outwards sluggishly, reaching the midline at most. Idiopathic cases are very common. If you find isolated sixth nerve palsy, although may occur in many cases in elderly especially, or diabetic patients in whom small vessel disease may be suspected, sixth nerve palsy can occur isolated cases in isolated findings. Only finding of sixth nerve palsy can be found in diabetic patients with ischemic infarctions. In idiopathic cases, no other cranial nerves are involved and improvement should occur within 2 months. Some of the causes that we can discuss, one of the identifiable causes is compression of the sixth nerve in the cavernous sinus by a tumor originating in the nasopharynx. Typically, severe pain in the head, anesthesia, and the distribution of the first division of the fifth nerve also occurs because it travels along with sixth nerve in the cavernous sinus. Anything that causes the brain to shift may stretch the sixth nerve because of its tumultuous route in the brain stem. So the nerve, because of the acute angle it makes before entering the Dorillo's canal. Thus, sixth nerve palsy may be due to large brain tumors removed from the nerve, to increase intracranial pressure, or to lumbar puncture, in which cases it is called pseudo findings of sixth nerve palsy, and it is very commonly seen not only with uh, the involvement of the sixth nerve itself, but other causes, many causes that cause increased intracranial pressure can cause sixth nerve palsy. Diagnosis complete sixth nerve palsy is easy, but determining the etiology can be more challenging. Excluding increased intracranial pressure and papilloedema during fundoscopy is very important. MRI CT scan can help exclude intracranial mass lesions, hydrocephalus, and direct nerve compression by lesions in the orbit, cavernous sinus, and base of the skull. Lumbar punctures indirectly tells about the CSF opening pressure, and it can detect leptomeningeal inflammatory infectious or neoplastic infiltrates entrapping the sixth nerve. Collagen vascular screen associated with connective tissue disorders like ANA, it may help to exclude a vasculopathic process. In many cases, sixth nerve palsy resolves when the primary disorder is treated. So you can see basically this is to elaborate that sixth nerve palsy has many medical and surgical causes, and it should be thoroughly investigated. So third, fourth, and sixth nerves, if combined, you must see for these things in patient. You must check for palpebral fissure, for symmetry or ptosis, position of the eyeball parallel, it should be normally parallel, or you must check if there is some convergent or divergent squint. You must check for ocular movements, full range movements. If there is any limitation, you must note, and the direction in which there is limitation of eye movements, you must note. You must check for nystagmus and in which direction there is nystagmus and the degree of nystagmus, which actually is not associated with the presentation here. You must check importantly for pupil. Pupil is usually with the function of the third nerve. As we saw, sixth and fourth and sixth nerve are associated with only extraocular muscles. Third nerve is involved with pupil as well. In pupil, you must check for shape, size, and you must see if it's dilated or if it's constricted. You must check for equality of pupil in both eyes, isochoria and isochoria. You must check for direct light reflex and indirect light reflex, and you must check for near reaction to accommodation and convergence. These are all things that are checked for, are tested in patients with third nerve involvement. Then after that, very important nerve, trigeminal nerve, fifth nerve, whose sensory fibers serve facial sensations along with scalp, as you can see here. These are sensory supplies, and motor fibers in the mandibular division innervates the muscles of the mastication. Which are the muscles of mastication? Masseter, lateral and medial pterygoids, and temporalis. So here you can see trigeminal ganglion leading to sensory nerves, and the motor fibers travel in the mandibular branch of the trigeminal ganglion, ophthalmic, and maxillary are pure sensory, but in mandibular has motor branches to masseter, temporalis, and pterygoid muscles. So it is a mixed nerve originating from the pons. What you check for in trigeminal nerve examination, you check for pressure points where the deviation emerges. It may be painful and indirect evidence that there is some problem. You have to take for sensations. Each deviation is tested separately. And what you check for sensation, pain, temperature, and light touch. Cranial reflex, blink response, in which the sensory component is by trigeminal nerve and its motor component is by facial nerve. You check for jaw jerk or masseter reflex. It is also included in the part of the trigeminal nerve examination. And in the last, you must check for motor function of the masseter, temporal, and pterygoid muscles. So somatic sensory trigeminal innervation is to the face. You must check in ophthalmic, maxillary, and mandibular distribution. Somatic motor component is for mastication, like chewing, tensor tepidi, tensor palatii muscle, soft palate associated with chewing, and eustachian tube patency. And you must check for light touch and pain on the forehead in all the branches of the trigeminal nerve. Origin from pons, as we discussed. It extends from the pons to the midbrain and also to the medulla and spinal cord. So it is a largest origin starting from spinal cord, medulla, midbrain, pons. Structure in the brainstem extends from midbrain up to the spinal cord. Three branches of trigeminal nerve: ophthalmic, maxillary, and mandibular. Motor is innervation to masseter and temporalis. This is just repetition. Sensory innervation to skin and mucous membranes in head, teeth, tongue, external auditory canal, and cornea. Sensation of pain, touch, hot and cold, and other motor functions are of masseter and temporalis muscle associated with chewing. Dysfunction, as we know, will lead to loss of sensation affecting all branches, indicative of peripheral injury. Brainstem or upper cervical cord injury may result in loss of sensation to one or more branches of the trigeminal nerve. It will lead to loss of corneal reflex, paresthesias, or severe pain indicative of nerve compression or irritation, for example, in trigeminal neuralgia. And in motor dysfunction, there will be deviation of jaw, loss of sensation, inability to bite and chewing, inability to close the jaw. Clinical evaluation sensation, we discuss test with patient's eye closed, evaluate pain, temperature, and light touch jaw, cheeks, and forehead, means in 3 distribution. This is the important slide to remember. Observe response and symmetry on both sides. Motor examination includes open the jaw, check for opening patient close normally or not, check for deviation of the jaw normally on inspection, then have patient bite down to something. Usually it is not performed during exam. Palpate for masseter muscle and temporalis muscle. Move jaw laterally against resistance to evaluate weakness or paralysis. In the motor examination of the cranial nerve, and usually this is placed at your exams. Corneal reflex with cotton wisp across the cornea, and you must observe for blink response. So sensory component of the corneal reflex is from trigeminal nerve, while its motor component is from facial nerve. In jaw jerk, you tap lower jaw with mouth open, not closed mouth, slightly open mouth. You tap lower jaw with your finger placed over the jaw, and you must check for reflex, either it is normal or brisk. What is trigeminal neuralgia or tic doulorex? It is a disorder of the trigeminal nerve producing bouts of excruciating, lancinating pain lasting between seconds to minutes, Usually it is very brief lasting pain, up to 2 minutes maximum, usually in seconds, and very common disorder. And it is along the distribution of one or more of the sensory branches of the trigeminal nerve, but most commonly it is in the sensory distribution of the maxillary nerve. But very painful problem, usually in elderly population. At surgery or autopsy, the causes can be found or that have been shown are intracranial arterial and less often venous loops compressing the trigeminal nerve. So it suggests it is basically a compressive neuropathy from subvascular loops overlying it. The disorder usually affects adults, especially the elderly. Pain is often set off by touching a trigger point or by activity. For example, patients usually complain that when they chew something, this pain starts. It is like uh, uh, very excruciating and lancinating pain started with sometimes patients shaving themselves, brushing, or chewing. Although each bout of intense pain is brief, successive bouts may be very debilitating. Its differential diagnosis includes neoplasm, vascular malformation of the brainstem, a vascular insult, and multiple sclerosis. Especially in younger patients, you find this trigeminal neuralgia, you must suspect multiple sclerosis. It should again be differentiated from this post-herpetic neuralgia. Post-herpetic neuralgia, which can be like this trigeminal neuralgia, but it is usually found in the ophthalmic branch and is differentiated by its typical antecedent rash, scarring, and predilection for the ophthalmic division. Trigeminal neuropathy may occur in Sjogren's syndrome or rheumatoid arthritis, but with sensory deficit that is often perioral and nasal. So, Sjogren's syndrome or connective tissue disorders, trigeminal neuropathy, usually, not usually, but may sometimes occurs. And the deficit, sensory deficit that may be found is perioral and nasal. Migraine is also a unique, sometimes, or in classic migraine, you may have hemicranial or unilateral side of the face is involved. So sometimes it is confused with trigeminal neuralgia, but you can easily identify it with normal examination results, and pain is more prolonged in case of migraine compared to this uh, brief lasting pain of trigeminal neuralgia for seconds to minutes. And the pain of the migraine is burning or throbbing in quality. Now, another important facial nerve, seventh cranial nerve, which is, as we discuss again, a mixed nerve having sensory and motor components. Sensory components, again, are somatic sensory and spatial sensory. Somatic sensory supplies posterior external canal. Spatial sensory supply test to anterior two-thirds of tongue. Somatic motor components supply muscles of facial expressions, while visual motor supply salivary glands and lacrimal glands. So it arises from bones in medulla. Innervation is anterior two-thirds of the tongue. Facial muscles, scalp, ear, and neck. What are its functions? Control of facial muscles for expression, motor limb to blink and corneal reflexes, secretion of salivary and lacrimal glands, and sensation of anterior two-thirds of tongue for taste. Dysfunction, as we can see, will lead to motor dysfunction, will lead to facial asymmetry, and facial asymmetry can be because of motor dysfunction in the lower facial nerve or facial nerve structure, or it may be because of facial nerve damage in cases of strokes, which is upper motor neuron palsy. If this ipsilateral facial weakness, right or left, indicative of damage to motor nucleus or peripheral component. Lower motor neuron, I will discuss laterally. Common cause is Bell's palsy. If contralateral weakness or paralysis of facial nerve associated with stroke, usually lower face of the uh, lower face is involved, and in this situation, upper motor neuron lesions are most common, like strokes. I will later discuss this concept. Parasympathetic component will, if parasympathetic component are involved, It may cause loss or excessive tearing or salivation. Again, visual sensory loss will lead to loss of taste. Combined problem can lead to speech difficulty and drooling. Usually there is combined problem. So this is how clinical evaluation is done. Motor function and sensory function of facial nerve. Observe for facial asymmetry and ask the patient to wrinkle her or his forehead, puff his cheeks, smile, show teeth, open eyes against some resistance, and blow the whistle. How you check sensory function? Test each side of tongue separately, because you have to test only sensory function is for test, not facial sensation. As you know, facial sensation, usually many of the candidates during exam in facial nerve make this mistake. When they are asked to check for the sensory function of the facial nerve, they check facial sensations. Facial sensations are from trigeminal nerve. Facial nerve doesn't supply the uh, sensory branches for facial sensation. It has sensory branches for taste sensation. This is how upper and lower motor neurons are distinguished. What is upper motor neuron? If there is a stroke, for example, here, cortex figment node, lower motor neuron, this facial nerve nuclei involved and its peripheral branch is involved, it will lead to lower motor neuron damage. Upper motor neuron and lower motor neuron damage is basically what happens in upper motor neuron lesions or in central paralysis. The upper branch is less affected because the rostral part of the nucleus is innervated bilaterally. Paralysis marked in the muscles in the lower half of the face on the opposite side. You can see the rostral part of the nucleus of the facial nerve is innervated bilaterally. This is innervation from both sides. And the caudal part of the nucleus is usually from contralateral side. So when there is some ischemic damage contralaterally, it will lead to what? Basically lead to paralysis of this lower part of the facial nerve arising from lower nucleus compared to the upper, because it is also ipsilateral supply from cortex. So upper part of the facial nucleus will be spared. While in case of low motor neuron nucleus, peripheral nerve paralysis, paralysis of all facial muscles will be on the same side. On the same side, there will be paralysis of all the muscles. In case of upper motor neurons, there will be paralysis affecting contralaterally and lower side of the face. Here you can see facial palsy again. This is upper motor neuron lesion. You can see the upper part of the face is not involved, lower part of the face is involved in case of upper motor neuron lesions. While in case of lower motor neuron lesions, ipsilateral paralysis occurs in upper and lower part of the face. Again, to show you an example, upper motor neuron lesions, you can see wrinkling of forehead on the affected side, while in case of lower motor neuron lesions, there's absent wrinkling and ocular is also weak on the affected side. Bell palsy is a very common example of lower motor neuron facial palsy, and is unilateral paralysis of sudden onset and unknown cause. The mechanism presumably involves swelling of the nerve due to immune or viral disease with ischemia and compression of the facial nerve in the narrow confines of its course through the temporal bone. Sometimes pain may be associated or may precede this Bell's palsy, pain behind the ear. Weakness develops within hours, sometimes to complete paralysis. The affected side becomes flat and expressionless. But patients may complain instead about seemingly twisted uh, intact side. In severe cases, the palpebral fissure widens and the eyes remains open. The patient may complain of a numb or heavy feeling in the face, but no sensory loss is demonstrable because sensory is not supplied. Face of patient is not supplied by the facial nerve. Facial sensation is from trigeminal nerve, so sensation will not be affected on examination. If there is more proximal lesion in temporal bone where this facial nerve traverses, it may lead to dysfunction of the salivation, taste, and lacrimation. As we know, parasympathetic fibers traverse along with it. and it may cause hyperacusis. Eighth cranial nerve or vestibular cochlear nerve, which is special sensory fibers for auditory balance. So it arises from pons and medulla. It is uh, innervation in the ear for cochlear and vestibular nuclei. Cochlear nuclei are associated with hearing, and vestibular are associated with balance, maintenance of body position, and proprioception. And dysfunction can lead to unilateral deafness. Loss, dysfunction of cochlea will lead to deafness, loss of sound appreciation, tinnitus. How you check it? You check it with some simple clicks or clock clicks close to patient's ear, and otherwise it is test with its function is test with Rodriguez and Weber test with tuning fork. Dysfunction of vestibular nerve will lead to vertigo and balance disturbances. Vestibular branch is usually not tested unless patient gives history of vertigo or some balance problems. And caloric testing, which is not routinely performed, is usually done by neurophysicians. About acoustic component of vestibulocochlear nerve, important, and it is asked to check in exams. You must check it bilaterally and compare with whisper or watch click. And sometimes Weber or Rini tests are also performed. Not really, but they may be asked to perform. You must have concept of these tests. Okay, what are these tests? Basically, in these tests, you differentiate between conduction deafness and nerve deafness. In Rennie's test, uh, air conduction is compared with bone conduction. Usually, air conduction is more than bone conduction. And some disorders, for example, sensorineural deafness, it may be reverse or absent. Weber test, in which you can see here, this tuning fork is placed on the scalp, and you have to check for lateralization of the vibrations either to affected side or to non-affected side, and will help differentiate the sensory neural deafness from other problems of deafness associated with conduction hearing loss. In Rennie's test, as I discussed, it evaluates air conduction and bone conduction, and we place the base of vibrating tuning fork on the mastoid process, as can be seen here, base of the tuning fork on the mastoid process, until patient can no longer hear the sound. When this vibration ends, then you quickly move tuning fork for near air canal. Ask the patient if he can still hear the sound or vibrations and compare hearing times. Normally, air conduction is better than bone conduction in normal results, while it may occur in reverse if there is some middle ear problem. Ninth, cranial nerve, glossopharyngeal nerve, which is somatic sensory nerve, which supplies posterior one-third of tongue, and some somatic sensory branches to middle ear. Visual sensory branches to carotid body and sinus, special sensory for posterior one-third of tongue, and somatic motor branches to stylopharyngeus involved with swallowing. Visceral motor branches to parotid gland for salivary function. Vagus nerve, I will discuss these combined. Vagus 10th cranial nerve. This is mixed nerve, glossopharyngeal, having sensory and motor components. Like vagus is also mixed nerve, having sensory and motor components. Somatic sensory of vagus is external ear. Its visual sensory is to aortic arc and body. Special sensory is for the test over epiglottis, and its motor branches for soft palate, pharynx, larynx, associated with functions of vocalization and swallowing. Its visceral motor branches are involved with bronchoconstriction, peristalsis, bradycardia, and vomiting, autonomic nervous system. The origin of glossopharyngeal is from medulla. Vagus is also from medulla. Innervation of glossopharyngeal is to mucous membranes of tonsils, pharynx, posterior one-third of tongue, pharyngeal muscles, carotid sinus, and carotid body. While innervation of vagus nerve is to the muscles of larynx, pharynx, and soft palate. It is very important parasympathetic component in innervation to all the structures of abdomen and thoracic viscera. Function of the glossopharyngeal or test from posterior one-third of the tongue. It is afferent limb of the gag. Its efferent limb is from this vagus nerve. So it is associated with swallow and sinus reflexes, while the function of the vagus nerve is very important. Vagus nerve associated with muscles of larynx, pharynx, and soft palate. Sensations conveyed from the heart, lungs, digestive tract, carotid sinus, and carotid body. Efferent limb of the gag reflex and swallow. Dysfunction of the glossopharyngeal is loss of taste, and sometimes glossopharyngeal neuralgia like trigeminal neuralgia can be found in patients. While dysfunction of vagus nerve will lead to again loss of gag reflex, swallowing reflex, loss of carotid sinus and oculocortic reflexes, dysphagia. Clinical evaluation of the glossopharyngeal and vagus nerve is usually done combined. They are not separated. They must be checked together. So what you check for, you basically check or see the patient's voice quality and check if there's hoarseness or some flaccid dysarthria. Ask the patient to open mouth and say ah, and observe for elevation of soft palate, midline position of uvula. This is how you will see, and you can see here the normal elevation of soft palate, and compared to this abnormal elevation of soft palate, there's uvula is, you can see here, deviated to one side. After this elevation of soft palate, you must check for gag reflex, and you must check on both sides for gag reflex. You must check for swallowing taste on the posterior one third, but usually it is not checked. What you can find if there is some abnormality in glossopharyngeal vagus nerve, there will be loss of voice quality. You may have hoarseness or dysarthria. Patient's uvula may be deviated towards non-paralyzed sides. This is paralyzed side, as you can see hanging here, but uvula deviates to non-paralyzed sides or normal side. In case of lower motor neuron, or in case of glossopharyngeal and vagus nerve damage, you will see uvula deviate to normal side. Swallowing difficulty or nasal regurgitation may be found. You may have vagal irritation and leading to its bradycardia and other sinus cardiac problems associated with autonomic nervous system. Glossopharyngeal neuralgia, like trigeminal neuralgia, is a rare syndrome. It is characterized by recurrent attacks of severe pain in the posterior pharynx, tonsils, back of the tongue, and middle ear. Cause is unknown, and sometimes tumor at the CP angle rarely can be found. Usually, again, men are more commonly affected, and in later age of middle age to old age patients can be found. As in trigeminal neuralgia, intermittent attacks of brief, severe, excruciating pain may occur, but in trigeminal neuralgia, as we discussed, the attacks are externally over the face, usually in the maxillary sensory distribution, while in case of this glossopharyngeal neuralgia, these attacks can be precipitated by movements, same movements like in trigeminal neuralgia, like in chewing, swallowing, talking, sneezing, but the pain will be felt internally in the mouth, and you can see severe pain may be associated with posterior pharynx, tonsils, back of the tongue, and middle ear. Like trigeminal neuralgia, Pain with glossopharyngeal is again unilateral, because uh, laterally you will find the, or you will, patient will tell you about the symptoms on the affected side of the trigeminal neuralgia or glossopharyngeal neuralgia. It cannot be bilateral. If it is bilateral, then you must doubt this diagnosis. Spinal accessory nerve, which is mainly uh, two muscles are innervated by it. As we know, it is pure motor nerve, and it supplies trapezius and sternocleidomastoid muscles. And you may find drooping shoulders if it is abnormal. It originates from medulla, supplies sternocleidomastoid and trapezius muscles. Motor function is sternocleidomastoid and trapezius, and its dysfunction will lead to muscle weakness in these muscles. You must, in clinical evaluation, palpate the trapezius muscles, as in patients. Here, this is the trapezius muscles. As patient shrugs shoulders against resistance, and you must evaluate strength if there is some weakness. You can ask the patient to turn head to one side and push against examiner's hand, palpate and evaluate strength of sternocleidomastoid. Here you can see the normally functioning sternocleidomastoid moving head contralaterally against the resistance. You must evaluate both right and left side, and they must be compared for any asymmetry. Hypoglossal nerve, the last, again pure motor nerve. You must observe tongue on the floor of the mouth for any asymmetry. Its origin from medulla. It supplies motor innervation to muscles of the tongue, which are involved with movement of the tongue. Dysfunction usually is unilateral. It can be bilateral sometimes. So unilateral again can be flexed paralysis or spastic paralysis. Flexed paralysis is from the lower motor neuron lesions or peripheral lesions, in which tongue deviates to the side of lesion, and there is associated atrophy and fasciculation. You must differentiate it from spastic paralysis or spastic paralysis of the uh, tongue, which is upper motor neuron type tongue weakness, in which tongue deviates to opposite side of the lesion. In lower motor neuron, tongue deviates to the side of the lesion. As you can see here, lower motor neuron tongue deviates toward the side of the atrophied tongue muscles. Here, muscles are also atrophied. You can see here, and tongue deviates toward that side. The spastic paralysis is not shown here, but the tongue deviates to opposite side of the lesion, and there's no atrophy or dysarthria, and ataxia of tongue can be present. Sometimes it is bilateral, for example, in medullary lesions and myasthenia gravis, and in such cases, you may find dysphagia, dysarthria, and difficulty chewing food. So this was all about this important